Greetings to the committee. My name is Fehintolu Bada. I'll be presenting the executive summary of my Diabetic project, which is titled Quarterly CDC Guided Diabetics Food Screening. Firstly, I would like to thank my committee chair, Dr. Rachel Davis Citron, which is my project chair in Catherine McAuley School of Nursing, Maryville University. And also I would like to thank Dr. Snell, which is my second professor in Nursing 705. She helped me. They all gave me the knowledge and the practice I require while working on this project, and also help with the methodology and the literature base of this project. I would also like to thank my community member, which is my site mentor, Dr. Jonathan Martinez in Tarzana Treatment Center, Palmdale, California. And also to my special appreciation go to Christian Espinosa, the clinical leadership team in Tarzana Treatment Center. Thank you for all the support you gave me. Through them, I was able to put this practice change in place in a primary care setting. The combined guidance created a project that is not only academically challenging, but clinically viable too. Let's go to a little background about the project. Diabetes is one of the most causes of morbidity in the world, and diabetic foot ulcer is one of the most preventable and expensive complications of diabetes. The CDC recommends a detailed food examination is done to check for neuropathy, infection, and vascular problem, more frequently every 3 months. It's recommended for people who are more likely to have this problem. Verker 2024 demonstrated that people with an history of diabetic foot disease had a greater risk of developing amputation by 19-fold, and even more when the basic comorbidity were held constant. In my project setting, which is Tarzana Treatment Center in Palmdale, California, this setting is a busy and large adult primary care clinic. Screening was only done yearly for diabetic foot screening, and there was a gap between the recommended and the actual screening rate, resulting in some cases of missing early signs of ulceration. This was a gap in practice rather than in diabetic care. That was what resulted in the project question. Would a structure, quarterly, CDC-directed screening process reduce diabetic foot ulcer-related hospitalization and reduce complications associated with diabetic foot ulcers when compared to current annual screening in the clinic? Review of the system. These are the literature that was reviewed for this project. The project was supported by literature in the area of clinical guidance, outcome research, risk stratification study, and patient education research. According to Bortin in 2019, it wrote that foot ulceration is the most common diabetic foot complication and the leading cause of amputation, with the condition being largely preventable. Emphasize the word is largely preventable if appropriate routine care is carried out. Ball and Tor in 2023 employed the wound ischemia foot infection classification system and found that the higher level of hemoglobin A1C and ischemia were important factors to predict the risk of a patient having amputation. Further emphasize the need to identify high-risk patients at early age. Galter also did a research in 2025, and he demonstrated that the electrochemical skin conductance can predict small fiber dysfunction early than the classical approach. Sogner in 2022 have proved that the foot digital foot 2. Facilitate documentation and communication of the screening. Lastly, Mehana in 2024 was able to determine that patient awareness and practice score increased significantly after 3 months of structured food self-care education. This body literature reinforced the notion that pairing, risk-based screening, and practical and patient education too were precisely what was done in this project. What is the theoretical framework? The theoretical framework that was used is the model. The model is developed based on the chronic care model proposed by Sari that includes 7 aspects of health system that facilitate improvement in chronic illness outcome: community resources, health system design, self-management support, delivery system design, decision support, clinical information system. The intervention were influenced by each one of these elements mentioned. The health system component was represented in the existing chronic disease visit with quarterly screening embedded as opposed to creating a new workflow. Decision support and clinical information system were implemented and supported by a reminder flag on the EHR and standardized documentation template to be used by all providers, leading to consistent screening. Patients were educated to check their feet daily. They were educated on what kind of footwear they can wear. They were educated on early reporting of symptoms when they see it. This project wasn't only a project of doing more foot exam when we used the chronic care model. It was also a matter of developing a system that was more reliable and that incorporates provider workflow, technology, and patient engagement in the diabetic food prevention system. What are the methods that was used? This project was a quality improvement project with a retrospective chart review of de-identified electronic health record from a community-based primary care clinic. The project did not involve direct contact with patients, which meant that it did not need to be reviewed by full IRB, but it was revealed in accordance to the institutional data use and also at HIPAA requirement outlined by Mardi and Percolis in 2021. The intervention occurred across 4 phases. The first phase is the baseline data collection. The baseline data collection was collected between May and October 2025. The revision of the EHR documentation template and staff in service education on CDC quarterly guidelines was done in November 2025, while the rollout of the screening of the study group was beginning in November 2, with the addition of EHR reminder flag, which will help in early child review and review inconsistent documentation in January 2026. The final implementation data collection and analysis of phase was done in March 2026. However, Shane in 2020 have also concluded that EHR data is a well-validated resource to assess this type of outcome study and that it is an easily accessible and useful source of clinical information which is not needed by staff or patient. Sample. So what are the samples that were used? The sample included all adults 18 and older, diagnosed with type 2 diabetes, and who had 1 or more clinic visits during the project period were included. Patients were with severe peripheral vascular disease that did not allow a foot exam, inadequate documentation, and patients involved in other trials could not impact Other channels that could impact the diabetic food screening were excluded from this project. They were not added. So we have altogether, we have 80 patients in the quarterly screening group and 79 patients in the annual screening group. Demographic and visit pattern variables, presence of a diabetic foot ulcer, its severity, its hospitalization in the previous 90 days, and food exam completion were attracted variables. All data were de-identified and treated as a de-identified as required by the EPA protection and presented in a meaningful way to allow for comparison of the two groups while minimizing the risk of patient privacy being compromised. What's the data analysis? So what do I use to analyze the data? The primary statistical test employed during this project is z-test for difference of two proportion that was chosen because Garver and Warner in 2017 report that it is appropriate for comparing categorical outcome. Complication present or absent from the two independent group of similar size. A one-tail test and a p-value criteria of less than 0.5 were used as is customary when comparing proportion. Because the hypothesis was directional, decrease rather than just change, rather than a two-tail test, I calculate the actual statistical power and a 95% confidential interval for the difference in proportion as well as p-value. Gravatar in 2017 stated that both reporting of the p-value and the reporting of the confidential interval are essential to providing a significant amount of information when determining if a finding is statistically and practically significant. What are the results after analyzing the data that we have? The result shows statistically and substantially significant benefit of quarterly screening. The incidence of complication was 12.5% in the study group, correspond to 10 out of these 80 patients, while 30.4%, which is 24 out of 79 patients in this control group, which had annual screening. This difference was statistically significant using the z-test for the difference of two proportions with a value of z equals to -2.75 and a p-value of 0.003, which is below the critical value on the 0.05 level, as described by the Gravatar in 2017. The 95% confidential interval for the difference did not contain zero, and the attained power was high, 0.87, indicating that a high power to detect a real effect, a relatively secondary benefit of the process that we use. Like digital screening tool, which facilitates workflow as outlined by Zugler in 2022, the EHR reminder flag was used to document the telehealth visit and follow-up scheduling, suggesting that the intervention extended beyond food screening to the entire care process. What are the limitations that we have? Several limitations should be considered when interpreting the result that we have for this project. The first thing was that the project was conducted in a single site and had only 3 months of follow-up period. So these findings are not generalizable and may not underestimate longer-term outcome, like late hospitalization, or reoccurrence of the diabetic foot ulcer, as noted by Auger in 2024. For patient engagement with food care over time, the project may not have sufficiently captured the variability of diabetic foot ulcer risk factor of comorbidity, self-care behavior, and socioeconomic access to the care that has been associated with diabetic foot ulcer risks in the literature, due to the amount of EHR documentation required. Screening frequently is significant, as Gawler reminds us, but other factors such as ischemia and high level of hemoglobin A1C also affect the risk of amputation and cannot be measured here. Exam and visit dates were not available on some records and were not included in the proportion of calculation, but this should have little impact on the result that we have. So let's discuss our results. Compared with annual screening, there was a significant difference in documented problem of diabetic foot ulcer that was observed with CDC guided diabetic food screening quarterly, with a difference of 17.9 percentage points. This supports the finding of VACO in 2024, which revealed that the patient with diabetic foot ulcer were a significantly increased risk of amputation, reoccurrence, and mortality. Highlight the importance of early detection of the issue. Perhaps most importantly, no additional personnel or technology was needed for this intervention that was proposed. All that was required was a new EHR documentation template and a reminder flag, which would make consistent quarterly screening possible in a busy primary care unit. The result further supports that of Miami in 2025, which indicates that integrating provider-led education with patient education on structured food self-care education has a potential to improve outcome even more by enabling patients to identify and report early warning signs themselves. The patient will be able to report this sign by themselves because they'll be educated on the symptoms to watch out for. Implication for practice. There are definite implications for practice in this project. Nurses and advanced nurse practitioners have a very unique opportunity to start their change in guidance-based care and practice to implement the national guideline like the CDC in a way that actually happens, and to align with the element of chronic care model described by Saris in 2021. The quarterly screening process allows for early detection, as opposed to when skin has progressed to ulceration, of changing in skin integrity and changes in their circulation, or when they already have neuropathy, which can be seen by the nurse and is a standardized process. There's also an equity dimension. Looking at lower income and minority population, they are more likely to be vulnerable to inconsistent food care and a clinic-wide approach to screening all eligible patients, not on a chance basis or on the patient's ability to fit into their treatment plan. It's more likely to benefit equity. Finally, its application in patient education results in the food screening being part of a larger chronic care model rather than be a standardized process. So to conclude all about this project, the project was successful in lowering the rate of documented food complication associated with diabetes, and it was done using a guideline-recommended approach, using a diabetic food screening protocol that was created in the CDC suggested manner and included in a standardized electronic health record template, staff education, and automated reminder flag. It did so with no additional staff or substantial new investment, which is relevant at the site and elsewhere to support sustainability. I also recommend expanding the evaluation to 6 to 12 months time point with additional hospitalization and amputation data and a risk strategized follow-up process for high-risk patients, suspect and continued staff, and patient education in the future. This project and the DLP program and the DLP program, this project and the DLP program, this project and the DLP program in the general has improved my ability to use evidence-based literature and disseminate the information into a process that can be used by clinicians and patients, a skill I hope to use throughout my career to promote quality improvement. And these are my references. Thank you so much.